Hi there, I'm Joel Proskewitz. I'm a health and fitness professional, strength and conditioning coach, and primarily a spine rehabilitation specialist. You are listening to the Soft Tissue OT podcast.
Good morning!
Just a flesh wound.
It's alive! You can't handle the truth!
Go ahead. Make my day.
Say all right.
Always live in awe of the glorious mechanism of the human body.
Hello, and welcome back to another episode of the Soft Tissue OT podcast. My name is Jordan, the Soft Tissue OT, and today is a very exciting episode that we have with a special guest, Joel Proskewitz. Joel is somebody I've been following along for a while and really a big fan of his work, and also his work that he's done with Professor McGill in the area of low back pain rehabilitation. So Joel's been involved in the health and fitness industry for 3 decades with a specialisation in spinal rehabilitation for the past 20 years. Joel has worked side by side with Professor Stuart McGill, who's head of spinal biomechanics at the University of Waterloo in Canada. He's also a previous podcast guest, and he's been working with Professor Stuart McGill in the area of low back rehabilitation. He's also one of only 2 people in the world who actually teaches alongside with Professor McGill. Joel is also the founder of the Spine Xchange, which is a community for spine surgery patients, which offers guided support and comprehensive resources for all things to do with the human spine. He's also the CEO of PerformanceRx, founder of the Spine Xchange, McGill Master Clinician, BackfitPro instructor, faculty member of the University College of London, and a permanent member of a spinal MDT at a leading London Orthopaedic hospital. So strap in for this one as we're discussing a lot of great content around there. And without further ado, let's get stuck in. Joel, welcome to the podcast. Thank you very much for being a guest.
Jordan, thanks for inviting me. I always say whenever I'm a guest on a podcast, I'm extremely honored and grateful because I obviously have a few stories to tell and that your audience is obviously interested in hearing. So thanks for having me on.
Yeah, no, thank you. And I know you're a very busy man yourself with all your various avenues that you're delving into. So I appreciate you taking the time. So without further ado, let's get stuck in. Just to give a bit of background to to the listeners out there, I thought we'd just start with giving your background, your journey. How did you get to where you are? And just give a bit of insight into the man behind the mystery.
Oh, I didn't realize I was a mystery man, Jordan, but just very briefly, I don't want to overbore your listeners, but my world in health and fitness started off 30 years ago, actually. Back in my hometown of Johannesburg in South Africa. And I and my then business partner started one of the very first personal training gyms in Johannesburg. And we ran that. And what was interesting is in those days back in South Africa, the rules and regulations with regards to who could work with pre and post surgery patients obviously were not as stringent as they are now. And as personal trainers, we hooked up with 3 of the main hospitals in Johannesburg, and we used to get a significant amount of pre and post-operative patients that came through. So really, I cut my teeth in the early days, very much on dealing in the rehabilitation world. So I feel like I'm a clinician from the word get-go. And, we dealt with everything from ACL reconstructions to a whole host of other orthopedic stuff. Very interestingly, I never dealt with many spines early on in my career. Anyway, it then evolved to a point of where in probably around about early 2000s, I started suffering quite significantly with my own back. And I always was having problems because I was very physically active, doing karate and a whole host of things. And I was seeking many different opinions. And eventually I landed up in front of a neurosurgeon back in South Africa who gave me an MRI and a bit of a diagnosis and said to me in no uncertain terms, Joel, I suggest you leave personal training never pick up a weight again. He said, because if you continue doing what you're doing, he said, I will guarantee you that I will see you back in my office in a wheelchair. And those words rung true in the sense of that they created a visual for me to go out and prove him wrong. So needless to say, I'm still 30 years in, and I'm still involved in the health and fitness industry. But a lot has happened to my spine over those years. I'm not in a wheelchair. I can walk. I can still train. And then I landed up moving to the UK in 2006. So I now live in London. I've got a facility here. And it was the same year that I met Professor Stu McGill, or who I'm assuming your listeners have heard of or know. And Stu and I started working together very, very soon after that time. And I now really, since 2006, have specialized in working with spines. And I have a whole host of roles that I play on a day-to-day and a week-by-week basis. I run my facility in the UK called PerformanceRx. We're a private gym and a rehab facility. This is where I see patients. I am a faculty member at the UCL University, which is the University of College London. And I am a lecturer to the pain management MSc students. I talk to them about the spinal biomechanics and how we assess pain triggers and a whole host of things. I also sit on a spinal medical meeting. I'm the only non-physician that is a permanent member on that team. And I interact with spinal surgeons, rheumatologists, sport and exercise medicine specialists, pain consultants. And twice a week, we discuss some very, very complex spinal cases, Jordan. So it's a fantastic honor, a fantastic education. And that's pretty much my life, and everything and anything to do with spines I'm involved with. So that's it in a nutshell, man.
Yeah, fantastic. Well, you did well to sort of, summarize quite a illustrious career in terms of being, specifically starting in the orthopedics realm, and like you said, not really being involved in spines to now being just involved in spines. So it's quite a journey to get there, and obviously quite high accolades for yourself being invited into those various MDT teams. So very interesting. And I think touching on that, I know we spoke a little bit before about you going in and seeing surgeries yourself. Is that something that you do quite regularly?
I do, Jordan. It's probably something that I'm not going to reveal too much about, just purely because of confidential aspects of it. But I'm in surgery on a weekly basis, and I see a whole host of things. I have, again, it's a fantastic education for me. I've created a very, very strong working relationship with a particular spinal surgeon. So we work very closely together, and I'm very, very grateful to be able to get educated on spinal procedures every week. So yeah, that is something that is a permanent feature in my daily work life.
Yeah, brilliant. And I think, as you touched on there, it'll give you so much, more background into working with patients pre-op, but obviously seeing the specific operations themselves, the hardware that they use, the techniques, they all make a difference as to how the patient needs to be treated in their rehab as well. So having that context must give you, an upper hand when rehabbing with the patients as well.
Well, what it does is it gives me a very real side to what I do. So, we spend a significant amount of time studying, reading research papers, reading textbooks, learning, going to courses. And then when all of a sudden you're in surgery with a real patient, and you see what you're supposed to see on an MRI prior to, starting the procedure. And then when you get into the patient and you're actually down at their spine, and you realize that the MRI can't reveal everything, and all of a sudden you need to change your game plan there and then, you get to watch how the surgeon sort of has to adapt very quickly. And as I say, it's an extremely amazing education. And, just on a very, very basic level, people always say, I feel that my psoas muscle, that muscle at the front of my tummy or in the front of my hip is tight. I'm going to get someone to put their fingers in there and release it. And, not 4 days ago, my fingers were on an individual psoas muscle. And I can tell you, you couldn't see my fingers, man. Okay. It was pretty damn deep. And you're not going to touch a psoas muscle by putting your fingers on someone's tummy or on their arms. So what it does is it gives me context. It gives me a reality platform where I can now sort of have the science and I can see it in person, real time. And it's fantastic.
And on that point of surgeries, I know you've been actually quite, not necessarily outspoken, but quite thorough with telling people about your own specific sort of journeys. And I believe it's, if you don't mind explaining a little bit about it, I believe it's 7 surgeries that you've had yourself.
That's true. It's not something I need to hide. It's part of my life, and we all wear our scars very proudly. So one of the reasons that I sought out Stu McGill many, many years ago was because obviously I'd heard about him in the health and fitness field, but it was for my own back. So I was dealing with a fractured spine, something called a spondylolisthesis, which is a very specific fracture in the spine. Because as a kid, I was a complete and utter nutcase. I was martial arts, bodybuilding, stunts, jumping off buildings, a whole host of things. And so I picked up this very common pathology called spondylolisthesis. And it was at that stage where the neurosurgeon said, I need to stop lifting weights because I'd land up in a wheelchair. And through my exploration and my adventure in trying to find a resolution, I came across Stu McGill. And Stu helped me out significantly, and hence our relationship. But I looked after my spine as best as I could for as long as I could, always understanding that there was the potential for surgery, because there's a natural degenerative process. And when you've got a fracture in your spine and the disc is degenerate and there's a whole host of things going on, sometimes you can't outwit Mother Nature, right? It gets the best of you. And that's when you have to sit opposite a really, really smart and a very experienced surgeon. And in lockdown, so March of 2020, I started to experience symptoms that I hadn't experienced previously. I started to experience bilateral sciatic pain down my legs and a whole host of things. And during lockdown, as we were allowed on government rules, as we were allowed to walk a little bit more and be outside a bit more, I was walking every day. And I started to find that I was starting to get a lot more symptoms of foot drop. So that's where the foot itself doesn't work, because one of the nerves that actually creates the electrical activity for the muscles to function and allow you to bring your toes up to your shin was being quite significantly compressed. So it just got to a point of where my toolbox got less and less. So I sat down with my surgeon. I've been working with him for a long time prior to him performing surgery on me. And I said, look, this is what's going on. And I said, I think mentally I've come to terms with it. I'm ready for a fusion. And he did all the workups. We did all the appropriate scans. We did all the appropriate tests. And in actual fact, we had a conversation, a 3-way conversation. It was him, myself, and Stu McGill. And, so we were all, because we all know each other, and we're all discussing the plans and what's going to go on. And on that basis, I went ahead with the surgery. And it's a 2-staged procedure. First stage went well. Second stage, I woke up and to no fault, and please, I must make this very, very well noted, to no fault of my surgeon, I woke up and I was in immense pain. I'm talking pain that I'd never, ever experienced before. And coming from Joburg, I've experienced a lot of action in my life, and I've felt pain in a whole manner of ways. But this was different. And what had happened was I had picked up something called a neuropraxia, which is a stretch on the nerve, because my surgeon had to realign my spine. He had to pull it back by 5 millimeters. So all the muscles and the tissues were compliant, except for my left nerve root. That was not compliant. It didn't want to be pulled back after 30 years of it being shortened. And the pain was immense. It was indescribable. The reason I had more surgeries after that was because my surgeon wanted to make sure that he had done everything that he could to make sure that that nerve was fully decompressed, and he was even playing with, possibly loosening the screws a little bit, et cetera, just to see if he could do something to lessen the tension on the nerve. And it was that, Jordan, that made me realize that in the midst of this storm, in the midst of this chaos, this particular individual, my surgeon, kept his head about him. He didn't get emotional. He didn't get panicky, nothing to that degree. He always had a plan. And I always knew that under his guidance and in his hands, he was going to do whatever he could do to put me in the best position, which is exactly what he's done. So from June 2020 to June 2021, I had 7 spine surgeries. I will never recommend anyone to electively go for spine surgery. All right. It is life-changing. But I have to tell you something. In the midst of my obsession of spines, those 12 months gave me an education that you could not pay for. So when I sit with patients, I sit with them and I wear 2 hats, right? I wear my clinical hat, but I also wear my patient hat. So when a patient says to me, Joel, because a lot of patients actually don't know I've had surgery, and they come in and they say, I might find this very difficult to describe to you because I don't think you'll understand, but I experienced this pain down my leg. And I'm sitting there and I'm thinking, well, I know exactly what you're talking about. So in a nutshell, Jordan, it was life-changing for me completely. But there's been many fortunate things that have come from it. And I'm in a good position now because I respect my new spine.
Yeah, I mean, we're going to touch about a little bit more, but respecting biology is what I always say to my patients. And it's great to hear you have that sort of level of trust. Obviously, you built a relationship with the surgeon and obviously Stu himself as well, Professor McGill. But just to have that level of trust in the surgeon himself and also your team around you to say, okay, look, this is not the end point and we're doing what we need to. We've got a game plan to attack it, and having that trust. And obviously, that's where the proof's in the pudding, coming out the other side.
It sure is.
Brilliant. I think we'll move on. Again, I'm cognizant of your time. Move on to establishing a bit of context. So one of my best sayings that I love to quote from Professor McGill, which has been quite widely quoted, is "It depends." And I think it's a great, overarching principle. And one quote that I picked up, following your stuff and heard speaking to a lot of other clinicians who know of you, one of your best quotes that I like is "Everything matters." So could you just delve into this to explain a bit about what you actually mean and context around people dealing with spinal issues as well?
Sure. It's quite simple. It's really not that complex. And it's exactly what it says on the tin. Everything matters. So when I deal with a patient, Jordan, from the very first time I speak to them on the phone before they come to see me, to even reading their email that they send prior to even speaking to me on the phone, I take absolutely everything into consideration. I take how they write the email. Some people literally will send an email and say, "Low back pain, please help." I'll have other people sending an email where literally it's 2-3 pages, everything from when it first began to every single type of pain that this individual experiences. So straight away, that email tells me who I'm dealing with. It gives me a little bit of an insight into how this person perceives their pain, how they perceive their life, what it's happened, or how it's impacting their life. And then obviously when I speak to them on the phone, I've got certain questions that I ask them. I get to understand them a little bit more. And it's possibly at that stage, I may even turn around and say to them, hold on, you've said something to me that indicates quite clearly that I'm actually not the person that you need to see. I need to send you to someone else first to get that cleared, and then you can come and see me. So I take absolutely everything into consideration, everything that they say. So I'm a details man, very much, and to the absolute hatred of my family, because nothing escapes my ears and eyes, right? So everything for me is details. And so even when they come in, right, what are they wearing? Right, even their shoes and their clothes and everything from that perspective tells me who they are, what choices they make in life. And essentially, it encapsulates a very strong principle that every therapist needs, right? And that is called the ability to have pattern recognition. Do you recognize patterns? And not just patterns within your assessment, but patterns of who this human is. What are they doing, right? Some people come in here and we've sent them an email of exactly what they need to bring. We've bullet pointed absolutely everything, and they come in and they haven't done anything. They haven't bought their MRIs. They haven't bought a change of clothing. So straight away, it's telling me, right? Are they fully involved? Are they in too much pain, right? So for me, everything matters until it doesn't, right? Because once I've gathered everything and I understand the pattern that this patient is putting forward, I can then get rid of the extraneous stuff, the stuff that just doesn't mean anything. And then I can hone in on what really matters. So for me, people will be dismissive of scans. People will be dismissive of technique or whatever it is. And I'm like, you know what? I may be dismissive of scans, but not until I've considered them, not until I've put them into the box of where everything matters. And guess what? If the scan doesn't matter, then fine, no problem, right? But I'm not quick to dismiss anything until I've put it into the box of everything matters. So there you have it.
And do you think that comes from, was that something you developed clinician-wise, or do you think that comes from sort of your history in martial arts and all that sort of stuff, reading your opponent and seeing where the weaknesses are and all the rest of it? Is it something that you've worked on, developed, or just sort of something you've always had?
70 to 85% subjectively, right, from martial arts. Definitely. Because martial arts does a wonderful thing for individuals. It takes something really complex and it teaches you how to break it down into small sequential parts so that you can then put it back into this big complex thing. So let's take traditional I come from a traditional martial art background, right? So I did Shotokan karate. So in Shotokan karate, as a competitive karateka, you've got two aspects. You've got forms, and then you've got sparring. Okay. So in forms, what you might do is you might take something that's got 65 or 68 moves, and you need to learn the whole form. But what you got to do before you do the whole form, you got to break it down into sequential parts. So that is an extremely strong teaching and educational tool. So what that allowed me to do is it allowed me to always take highly complex situations, whatever it was, whether it was when I was a strength and conditioning coach, if I was training Olympic athletes, which I've had the absolute honor of doing, or whether it's, negotiating a business deal here in PerformanceRx. If something is complex, how in my brain can I break it down? And then obviously working with Stu taught me the pattern recognition with regards to spinal pathologies, right? So now I've got the martial arts, I've got working with Stu, now I work with my surgeon, with all of my other individuals. Last week I interviewed a very, very prominent pain consultant here in the UK, and listening to what he's saying and recognizing the patterns, all of those things. So that for me is what it is. And I truly, truly give gratitude to my martial arts instruction and involvement in my early years.
Interesting. Brilliant. And I think, as you said before, it's so important, until it's not important, number one, but getting through to the patient, right? Obviously, as clinicians, there's always a buzzword of rapport and developing rapport with the patient. And I always say each individual is individual, right? The way I coach a 98-year-old grandmother to do exercise is going to be very different to the way I coach a 16-year-old, highly testosterone-fueled gym goer. And being able to identify that so that you can actually, marry up to what as you said before, what the patient is actually seeking, I think is so important, because, you can have the best advice in the world and, be the best, surgeon or clinician, whoever it is. But if you can't communicate effectively to your patient, it's pretty worthless.
Communication is key, man.
Absolutely. So following on for that point, we touched on it a little bit there, but there is, social media in itself is a whole nother thing, but there's a lot of debate in the health field around technique. And we touched on it a little bit there about, technique and whether it's important or not. And I know there's a few clinicians out there who are quite boisterous or quite loud about saying, lift how you want, technique doesn't matter. What is your, personal insights into that?
Hey, man, if that's what they believe is right for their patients, then I can't argue against that. It's not for me to put up that argument, right? Because I'm too busy dealing with people who where technique does matter, plain and simple, right? So for me to get into the argument of does it matter or doesn't matter, it's futile. Nothing's going to come of it, right? Because I need to relate it to the person who's in front of me. And in my world, very rarely, if ever, has the dismissal of technique been the resolution for that individual's back pain. And Jordan, I'll tell you hand on heart, I'm not going to sit here and discuss papers and research papers and those type of things, because we can cherry pick any paper to strengthen our biases or not. I will tell you this, okay, to talk about just experience in working with individuals, right? You need to have clinical reasoning as well, because you can quote research papers, and yes, they are good and we need them, right? Because we need guidelines, right? Every practitioner needs guidelines to work with, right? But you also need clinical reasoning. You also need real world experience. So the thing is, I'm extremely busy. I get to see many, many patients in many different presentations. Right. As recently as 3 days ago, I saw a cancer case. Right. So on that basis, right, I can have every paper in the world, but I need to understand the patient, how they're presenting. And I will tell you this, by the time someone comes to see me, in my world, technique matters. Plain and simple. It really does. Now, by the same token, I've had people come in here and they've been told that they should never bend their spine, wherever they got that advice from. It's irrelevant, right? And they will come in here and they will literally take their bottle of water and they will deadlift their bottle of water to put it down on the desk or on the bed or wherever, all right? And they are constantly in pain. And then what I'll do is I'll test them, because I never give anyone anything until I have an objective outcome from my test. Otherwise, it's my opinion. Otherwise, just stick me on social media and I'll just be one of those guys, right? So, and also when you do something and you demonstrate it to a patient, the patient turns around and it's a bit of an aha moment. Got it. No one ever tested me, so I don't know, right? They just said, don't bend my spine. So if I test them and we deduce that flexion or a little bit of flexion is actually not a pain trigger, right? Because there's a difference between flexion intolerant and end range flexion intolerant. At least in my world, there is. Okay. So on that basis, I will teach them it's okay to bend your spine a little bit, to put down a cup of water or pick up your iPhone or whatever it is. Because if you deadlifting or using a deadlift technique to do that and you don't have symptoms when you do that, there's a mismatch, right? So on that area, that's maybe where technique doesn't matter, but I wouldn't even go so far to say that. I'd probably say that technique does matter. And in actual fact, you need to have a little bit of flexion. Guess what? You're not going to blow a disc, because also remember one thing. There's a difference between a flexion intolerant dynamic disc bulge and end range flexion intolerance, which could even be from facet joints, right? So again, you can't, that's why for me, everything matters, man. Everything. When I do a 3-hour assessment, and I learned this from Stu, right? And I couldn't quite, in my early days when I was a youngster, I couldn't quite gather what he was saying. I used to think, you don't have the endurance, Stu. He always used to say, like, after a 3-hour assessment, he's done, he's finished, he's exhausted. And I used to sit there, big man, youngster, think, I could do 3 in a day. Let me tell you, when you get to the stage of where you're dealing with highly complex situations, which is what I do, I don't deal, very, very rarely, Jordan, do I deal with your flexion intolerant dynamic disc bulge. I really don't. Okay. Those guys can fix themselves up with back mechanic. They don't need to come and see me. Right. So by the time they're coming to see me, man, oh man, those 3 or 3.5 hours or whatever I'm doing, I'm done for. Right. Because it's like I've run a marathon. I've put so much mental and physical energy into that, man, for me, technique matters massively.
I completely agree. And I think, as you said, that's individual to the context. And that's what I always say to my patients as well, is that technique matters, but it's contextual how much it matters, right? So, I think we've covered that topic nicely, and you've done well with it. So, wanted to move on to more specific injuries and conditions. So, one that you actually spoke a little bit about earlier, which is always a tongue twister to say, is spondylolisthesis. Can you explain how do I put this, as simply as you can, given that it is a complex thing? Could you briefly explain what it is and sort of how it occurs?
Yes, very, very, I can. And sorry, I'm going to go out of camera for a second. And the reason I can explain it simply is purely because I have a very, very good friend by the name of Jerome Fryer. And what I do is I really push our friendship to the edge. And I constantly ask him to custom make me a whole bunch of stuff, which is sitting on my desk right now. And he phones me and he says, I don't think I can do it. And I say, Jerome, I got more faith in you than you do. So I said, make it for me. And he does. So I asked him to make me a spondylolisthesis model. So Jerome is from Dynamic Disc Designs, right? So what we're looking at here, Jordan, is we're looking at the human lumbar spine from the front. I'm going to turn it side on. Here's the tummy and here's the back. Now, if I turn it to the back, you will notice that you've got little joints at the back of the spine, and those are called the facet joints or facet joints. And just under the facet joints, you've got little bones there, or that portion of the bone is called the pars interarticularis. Now, the pars bone is the thinnest portion of the bone at the back of the spine, and the one that has the least amount of blood supply, which makes it a highly fragile portion of the spine. Okay. Now, usually what happens, spondylolisthesis, right, in simple terms, basically means a slippage of one vertebral body over another, right? But you get different categories of spondylolisthesis. So I'm going to talk about 2 very specific categories. I'm going to talk about one, which is caused by a fracture in the pars bones, and we call that an isthmic spondylolisthesis. And generally, you get an isthmic spondylolisthesis because of the fracturing in the bones, and it's due to repetitive stress, right? So lots of bending forward and arching back repetitively. So in other words, there are many athletes who are predisposed to an isthmic spondylolisthesis because of the nature of their sport, vis-a-vis gymnastics, Olympic weightlifting, and cricket fast bowling, funny enough, okay? You then get another presentation of spondylolisthesis called a degenerative spondylolisthesis. Now, that's very different to an isthmic. So a degenerative spondylolisthesis is usually the affliction of an older population group, most of the time. And what it's caused by a loss of integrity of the facet joints. So they become highly arthritic and they lose their ability to stabilize and hold the spine in alignment. And then what happens, as you can see here, the bone slips forward over the bone below, and that's a degenerative spondylolisthesis because of these, and that's an isthmic spondylolisthesis because of the fracture, which you can clearly see right over there. So in simple terms, that's what a spondylolisthesis is. Are all of them symptomatic? No, not at all. Some people will walk around with a spondylolisthesis, whether it's degen or whether it's isthmic, for years without even knowing. And then all of a sudden they'll get a little bit of back pain and they'll go get scanned, and then they'll get to see that there's a whole host of things changing in their spine.
Beautiful. Well done, I have to say, taking something so complex. And obviously Jerome, I'm a big fan of his. I've got quite a few of his models, not as big as your collection, I must say. I'm quite jealous. And I always see Jerome, posting some of the stuff and some of the weird and wonderful things he come up with. I'm like, it must be another one of Joel's special requests. So it's brilliant. Having that visual aid to also explain it to patients makes a big difference for sure. Now, just quickly want to touch on in terms of, I know you identified gymnastics, cricket fast bowlers. My cousin was a fast bowler, suffered a bit of a stressy himself, and is from the repetitive loading. Very simplistically, is it can it be without having any disc issues, or is it the disc starts to lose some stiffness and then we start to see some loading of those? Does it matter?
Well, it depends. So with regards to an isthmic spondylolisthesis, that generally the primary cause of that is the fracture in the pars. So as I showed you, with the degen, yes, it usually starts with disc, right? And then obviously the facet joints get loaded. And then what happens is the facet joints degenerate to a degree of where they can't hold the spine. So therefore it starts to slip forward. Now, the presentation and the symptoms between a degen spondy and an isthmic spondy are very, very different. Okay, they're not the same. Therefore, the surgical intervention for both of them, if they do require surgery, are usually very different, right? So again, and you can generally classify the symptoms of a degen spondy versus an isthmic spondy. They present very differently. So, and obviously with the disc, when you've got that shear force, so shear essentially means going, the vertebral body will go one way, when in actual fact, the vertebral body underneath is then, it's having an opposite load imposed on it, okay, an opposite force imposed. And the disc is not fantastic at resisting shear forces. So the disc will degenerate, the facet joints will degenerate, etc., etc., and then symptomatic presentations will occur.
Yeah, interesting. And on that, moving through to a different type of fracture, so you spoke about one there, but end plate fractures. It's something clinically that's quite interesting to myself. I've done a little bit of research around it, obviously reading a lot of literature that Stuart McGill, Professor McGill has written as well. But can you explain what an end plate fracture is in the spine? And could you sort of explain how this may occur, and if it's involved in the spine, is it something that can be pathological? Because often I hear a lot of either clinicians or radiologists that don't even report on things like that. Again, they might not necessarily be generating a specific pain, but what they can do is contribute to dysfunction or change in the biomechanics. So could you briefly explain end plate fractures?
Sure. I'll use two of Jerome's models again. So one he custom made me, and another one I think he's now making regularly. So if we take a spinal segment, so a motion segment, which is two bones and a disc, right? So again, I'm going to show your viewers from this side. So here's the back of the spine, here's the front of the spine. Generally, what tends to happen, right, is discs herniate backwards most of the time. Okay, we're just speaking simply. And as they herniate backwards, they can press on nerves and a whole host of things. However, there's a very interesting filtration system where discs get their nutrients, right? And it's called the end plate. Now, the end plate, if I use this disc here, so this is a replica of a human disc, and I've had a human disc in my hand, and I can tell you this is pretty damn close, right? If I turn it this way, Jordan, you'll see that there's this little cartilaginous filtration system, okay? It's like a filter, right? Like a mesh filter. And that allows nutrients to go into the bone and then filtrate into the disc, etc. Okay, so that's where the disc actually gets. So here we've got a replica of a human disc, and here's the end plate. So that end plate essentially is a filtration system. So as the blood comes into the bone, right, because all the nutrients come into the bone, and then it goes through the end plate and it feeds the disc. Now, what generally happens? So the end plate is the interface between the bone and the disc. That's how you've got to look at it. And then what happens is every time you herniate a disc, whether it's a bulge or a prolapse or herniation, whatever term you wish to use, it will affect the end plate, right, to some degree or another. And in people that have had significant end plate derangement, what can happen is you can actually crack the end plate, and that interface can then start to affect the bone itself. And the disc, if it's still quite well hydrated and it's got still a lot of water and collagen and a whole bunch of stuff in it, you can start to get, beside a posterior herniation, you can get a herniation that either goes down into the bone or into the bone above. And we call that an intravertebral herniation, right? And usually what tends to happen with end plates, for the most part, Jordan, end plate fractures that are provocative, that are pain generators, usually occurs in individuals, athletes, or whoever that do quite a lot of heavy lifting, right? So where they're placing significant axial load through their spine. So, for example, heavy power lifters or individuals that are having to do lots of jump, like long jump or high jump, or people that put that one-time direct load through their spine. Because what we also know from Stu's research is that the primary shock absorber of the spine is the bone. So if you are putting significant load through your bone and you've got a disc derangement, together, all right, they can create the perfect storm to have an intravertebral herniation. And there's many different names, right? Some people will say end plate derangement. Some people will say Schmall's node. That's generally how radiologists will report. They'll say multiple Schmall's nodes. Now, we also know this, is that a lot of people have Schmall's nodes, which is this, and it's completely asymptomatic, right? Very little explanation for that. Don't know, right? So that's why just seeing a Schmall's node on a scan doesn't necessarily mean that that individual has any type of pain generator from that particular Schmall's node. What we do know, though, is when you do have a Schmall's node or an end plate derangement, right, it lessens the height of the disc. So that can be a contributor of further herniation at the back of the spine. So again, you'll look at that and you'll believe it's a posterior disc herniation, but there could be an end plate involvement in that. Generally, what tends to happen in end plate pain generators is any type of axial load is quite provocative, right? So if you put a direct load through the spine, because what the end plate degenerative change may cause is it may cause an inflammatory response within the bone itself, right over there, okay? And now we start going into a completely different category of things, right? And that's what we call modic change. And then you've got modic 1, modic 2, modic 3. So can you see, very difficult to just purely isolate one thing, right? Because it's very rarely just one thing. Now, the cause may initially be a disc, but it then can have an end plate derangement. You can then get a Schmall's node, which can then turn into a modic change, which can then turn into a whole host of different things. So again, you know, the sometimes what you will get is it's never just one structure, or at least in my world, right? By the time the patient comes to see me, it's not your fresh disc. I very rarely get to see the fresh disc. So that's summing up. That's what an end plate derangement is. Okay, so essentially it's the derangement of the filtration system between the disc and the bone, which can lead to a whole host.
Wow, interesting, and well summarized as well. Appreciate that. And like you were saying before, you know, it can be a whole cascade of events that we see happening. And obviously, by and large, the fresh, you know, posterior disc herniation, flexion intolerant, relatively simple enough in terms of if you can identify it correctly, know how to treat it correctly. But you know, that can lead over time, disc loses its stiffness, loses ability to bear load, and then we have a whole cascade of events. So back to what you were saying before, everything matters until it doesn't. So beautiful summation there. And I know you spoke previously about the spondylolisthesis, about shear forces on the disc and forces on the spine. So could you just go into a little bit more detail about that? Specifically, I know you talked about how the shear forces in between the two vertebral levels, but can you just talk about what actually happens at the disc itself, and then very simplistically how that translates into you know, exercise consideration, for lack of a better term?
Okay, I'll try to do it as simply as I can. Let me find a model to explain. Right, so here we got an L4 and L5. Now, the disc is a ligament structure. So its primary role is to connect bone to bone. That's its primary role. Its secondary role is to have enough fluid inside of the disc to maintain a distance between the two bones. And its third role is to allow for a little bit of motion at that segment. Right, so that's what the disc does, and then obviously its fourth role is a minor shock absorption role, because the primary shock absorber is the vertebral bone. So what tends to happen is discs generally don't like shear, right? They don't respond very well to shear forces. So a shear force, in simple terms, I'm just trying to make sure the camera can see this, is where this top vertebral bone will slide forward. That's not the best demo. I'll just use a spondy, okay, if I can. So if we look at this level there, right, that's a shear force. So you can see. Now, as it goes forward, it puts significant load through the disc, and the disc doesn't quite like that. And if it's sustained, or if you've got external load on that, right, you will then start to produce more shear. Now, what we've seen, especially in Stu's research, is that the disc can tolerate more load when the muscles at the back of the spine are contracted to buttress against shear, right? So in other words, in simple terms, if I lean forward, what happens is, let's say I lean forward and I flex my spine, and I bear load through the spinal discs and segments. Gravity takes my rib cage and pulls my rib cage forward over my spine. When those muscles at the back of my spine are lengthened, they are electrically more quiet. So in other words, they're not responding optimally to buttressing or offsetting the shear force. Right? So what happens then is, if I shorten the muscles by changing the curvature of my spine, the muscles will then contract, and because of the orientation of the fibers, they'll be able to buttress the spine and allow the spine to be in a less sheared position, or there will be less shear forces on the disc, right, in that position. However, right, shear can take place posterior to anterior, and it can take place anterior to posterior, right? So again, a lot of people will overdo that massively, and they can start to have different shearing directions on the disc as well. So it's not just through flexion, right? So you've got to find that optimal position where you've got optimal muscle contraction, but not too much load through the spine, so that the spine can actually tolerate the combination of shear, compression, movement, etc. Okay. So, and again, with physics, there's never just one force. It's never just shear. It's never just compression. You can't subcategorize it just to that. Yes, you can in the laboratory, all right, and you can just play shear, right? But in human movement, it's always compression, shear, flexion, a whole host of things, right? So in simple terms, putting a lot of shear through a disc, it doesn't particularly like that. And it takes me back to the degen spondy, right? Is where if the disc starts to derange, right, and you then start migrating the shear loads onto the facet joints, so onto these little guys here, you then start to get significant changes, arthritic changes in the facet joints. The facet joints can then become degenerate, and then you can start to create the shear force, okay, through the vertebral body. So can you see it's all a combination, Jordan? Okay. It's never just one thing. It's never just a disc. It's never just a facet. It's never just an end plate, right? It's a whole bunch of things, right? What we need to do is we need to determine, right, if there is a primary structure that is contributing to the majority of the pain. And if we can't reduce the pain through a conservative movement intervention, can we be more precise in determining what structure may require a medical intervention to reduce the pain so that the patient can get on with life?
Fantastic summation. And as you said before, and we spoke about it on the previous topic as well, is that it's, a combination of things, but it's all relevant. And I think that's the big key as well. How much relevancy it has is dependent on the person, their mechanisms, their history, all the rest of it. But, keeping those things in mind when you are assessing a patient, also prescribing them some exercises as well. So it's all contextual to the individual. So I appreciate you explaining that as well as you can without actually having a specific context to do that. So you touched on, which is basically to our next point there, surgery, the oral surgery. Obviously, yourself being a surgical patient.
Recipient,
apologies.
I like to say I've been a recipient of 7 spine surgeries. I'm not a patient.
Right. I love it. And so on that point, obviously surgery has its role. I think, there's a lot of great surgeons. We've also got some brilliant ones here in Perth, luckily in Australia too. And there's some great ones obviously in the UK as well. But there is a time and the place for that. Now, again, without giving you a specific person, it's hard to specifically say, but what are the key sort of things that you're looking for in an individual that might say, okay, I think, conservative or non-operative, I should say, may not necessarily be enough or may not be the situation for the person? What are the sort of red flags that you look for? And then you go, okay, I'm going to refer off to a surgical consult.
I don't need a person because I can tell you, I've got it quite clear in my head, plain and simple. If someone presents, right, either with back pain or leg pain, and you can change their back pain and leg pain, they may not be a surgical candidate at that time. Okay. It doesn't mean that they won't potentially have surgery in the future, but you can work with them. The people who I know straight off the bat are going to land up for surgery is people that have got neurological deficit, right? Not pain, neurological deficit. So there's a progressive deficit. So in other words, last week they could move their foot. This week it's getting worse. They're starting to lose even more and more function at their ankle or at their knee or at their hip, right? If someone's got intractable pain, I'm talking pain that is just progressively getting worse. It's not getting better. There's no positions, there's no postures that can reduce the pain. You've got to send them off, right? Because that nerve could be so massively compressed that they haven't got neurological deficit, but the pain's intractable, right? And it's to a point of where they can't stand, they can't move, right? Those people generally, okay, will go see my surgeon. Then obviously the red flag factors, Jordan, right? So bowel, bladder, genital disturbances, those type of things, right? But again, do I see impending cord recliner? So people that have the potential to have major problems? Yes, I do see them, just purely because I see such a wide variety of patients. And I've saved many, many people, right, from a full-blown cord recliner because they phoned me, and straight away I can see, I've seen them on Zoom or Skype or whatever, and I've said, I'm not touching you, I need you to go see the surgeon. And literally within 24 hours, they're having a decompression surgery, right? It's happened to me many times, okay? So with that, when I see someone come in and they've got progressive neurological deficit, or a very interesting one is a painless neurological deficit. So they come in, they've got no pain, but they can't move their foot, right? That for me is a red flag. That's like, I need you to see my surgeon, right? So again, there are very distinct presentations that are not going to be treated conservatively. And because I live in that world now, and because I'm very involved with surgeons and the medical world, I can very much make that distinction as a person. As recently as this morning, right? We had someone email us last night saying that, listen, they want to avoid surgery, but the surgeon wants to do surgery because there's potential for cord to try and, relax their brain for the next few days, and then they'll come back. And I saw the email, and straight away I phoned the patient, right? And I started to get more information from the patient. And I said, look, if the surgeon has said to you, and I know who the surgeon is, right? And I said, if the surgeon has said to you, you've got to be very careful because there's a high risk factor of you getting full-blown cord recliner, I would consider delaying my trip to go get a mental rest from what you're experiencing. Because if you're out of the country and something goes horribly wrong, you're in trouble. And he was like, didn't think of that. So again, there are very, very distinct things, pattern recognition that I get to see where I can tell you whether you're you need to go. Now, I can't tell you whether you're a surgical patient or not, right? I'm not a surgeon, but I can tell you as to whether I'm happy to deal with you or I need you to go see my surgeon first, and then I'm happy to deal with. So there's a role for surgeon, Jordan, and then there's a time when surgery is performed and it shouldn't have been performed, right? But again, I don't deal really with those surgeons, right? The surgeons that just do surgery because that's what they do, that's not the realm of the people or the organization that I'm dealing with. I'm dealing with surgeons that will do everything in their power to not do surgery.
Mm-hmm. Fascinating. Again, individual context is so key. And I like that you're saying, trying to suit the individual, and like you said, reading the person himself, back to our start of the conversation, is so key, right? Person, your example that you said of emailing through. But again, it's good to have a multidisciplinary team around you that you can trust to refer off to a surgeon or even a pain specialist or something along those lines, who you trust their advice and know that they're going to do right by the patient, not just because that's what they do, as you were saying. So on that point, adjacent level disease. So it's becoming more of a spoken about topic now, and I think we'll elaborate on it a little bit more, but when somebody has a surgery, for example, a fusion, and their two segments are fused together, they got rods and hardware in there, you may have addressed or removed that segmental motion from those segments, but the motion or movement requirements of an activity are still there. And so they don't just disappear, and what will inevitably happen if you don't fix the movement patterns as well and address the cause, not just, the symptomatic pathology, then what can happen is you inevitably change or migrate that stress to a different level, adjacent level, either above or below where you've got the actual surgery itself, because structurally their bodies have changed, right? Structurally and functionally, their bodies have changed. So what are your thoughts on this? And is this something that you see in patients yourself?
Jordan, that topic can be a podcast in and of itself. I speak about it literally every day, right? So because I see so many post-operative patients, right, they had a fusion surgery, right? So to give your listeners context, with a fusion, right? A fusion is done because there's a segment, there's a surgical target that requires immobilization, right? Either there's a fracture, there's a whole host of things, right? Or it's intractable back pain, not leg pain, intractable back pain that just has not responded to other surgeries or any conservative measures. And they've seen on certain scans that there's instability there, okay? So what the surgeon will do, there's many different ways to fuse a segment, but what a surgeon will do in most instances, they'll approach the spine from the front, they'll take the disc out, they'll replace it with a cage, which looks like a disc, all right? But the cage is then screwed into the bone, and inside of the cage is bone graft, right? So synthetic bone graft that will eventually fuse those two segments together. And then at the back of the spine, to make sure that the fusion takes place, they put in screws and rods. That's a pedicle screw. It's a real pedicle screw that was in me, okay? So they took these 4 out and put 4 new ones in, right? But anyway, so they'll put pedicle screws and rods, and that is so that the fusion takes place. The screws and the rods are not the fusion, right? The fusion is what happens inside there. Over, let's say, 18 to 24 months, that takes place, and then this is completely immobile. And what will then happen is movement doesn't just disappear out of your body, it migrates to different joints. So the movement that was there will then get taken up at the joint above. Now, they say that fusions are the primary cause of adjacent segment, so that's the segment above, of the disease or the deterioration or degenerative change in that segment above. I wouldn't go so far as to say fusions are the cause. I would, me personally, and this is, I don't have evidence to this, I'm contextualizing it, I'm telling you because I deal with this every single day of my life. I would probably go so far as to say it's not the fusion that's the cause, it's how the spine is treated post-fusion, right? So it's what people have been told. Now, it's not the patient's fault. I'm not blaming the patient, right? But it's what the patient has been told that they can do with their spine post their fusion. So I have another hashtag, Jordan, not just everything matters. My new hashtag that I'm going to spread around, okay, even though I'm not that prolific on social media, is respect your spine. Hashtag respect your spine. And let me tell you why. Because once you've had surgery, if you are given the tools to respect your new spine, that doesn't mean you can do more or less. It just means you have a different mindset on what is now occurring in your spine. I'm of the belief, if I ever was to get involved in research, this is the topic I would choose, is can we reduce adjacent segment disease in post-fusion patients with teaching them how to move differently and teaching them how to avoid extraneous stress on those adjacent segments. Okay, so as I say, and there's plenty of research, right, on PubMed, the Spine Journal, everywhere. on adjacent segment disease, plenty, right? And I speak about it literally every single day. The majority of the research has been done in the cervical spine, right? More so than the lumbar spine, because generally the cervical spine is extremely mobile, right? So, and then fusions take place there because of they usually have to if there's any type of compression on the spinal cord. And then what happens is people go back to just moving their neck as normally as possible because they don't want to, be a bit robotic. And so there's a significant research on cervical ASD. But I believe it's a very real thing. I see it every day in clinic. And if I could get involved in research that can follow patients and change how they move, which is an ASD long term.
Fascinating thing, and again, I think it goes to understanding the cause or causation behind issues. As we said, it's a lot of times progressive from one issue develops to another cascaded event from there. And as you said before, it's not about just fusing a segment or stopping that segment from moving. We've got to actually address the underlying issue from there. On that topic, progressing through to rehab and performance specifically, and I think it's a good interlude into another one of, I think we're actually discovering a few of your hashtags here as we're going through, but Joel's 70% rule. Can you explain what that is, and also sort of give a bit of a practical application of how you yourself, but also maybe patients apply that rule? Sure.
So it's a subjective statement, right? 70% rule, because 70% is different for everyone.
Of course.
Basically, what I was doing is I'd been asked to shoot a video I've got a spine surgery business called the Spine Xchange, right? So we look after spinal pre and post spine surgery patients. And a question I get often is, Joel, how do I train post spine surgery, right? And I've been told I can go do whatever I want to do, etc. Once a person understands what they can and cannot do with their spine, which is a different subject, I always like to say to people, consistency will trump intensity for most patients. Now, I'm not talking about your athletic population, right, who need to have intensity, right? But at the end of the day, right, the athlete, even if they've had a fusion, may turn around in their head and say, well, I couldn't care what happens over the next 5 years, because if I'm disabled in 5 years' time, at least I'll have, $50 million in my bank account and I can look after myself then. Okay. Now that's a different thought process compared to Mrs. Jones, who walks in, right, and had spine surgery and just wants to get physically active again. So the context is for Mrs. Jones, not your elite athlete. And I always say to people that if you can train, whatever that is, whether you want to do Pilates, yoga, gym training, whatever we've decided is best for you, right? If you could stop before you empty your gas tank, right? So if you could stop at approximately what you perceive to be 70%, you can then derive the benefits of that workout. You can allow your body to fully recover so that you can get in the gym or in your yoga studio or Pilates studio, or whatever you want to do the next day, and you can train again to 70%. And if you can do that 3, 4, 5 times a week, it's going to serve your spine better than going absolute 100% head in bucket vomit twice a week, right? Where your body may not be able to recover, because you now have a second chance, right? The spine surgeon, for all intents and purposes, has done a great job, and they've given you a second chance. Don't go below that chance. So rather just stop before you cross over that finish line, right? And then start the race again the next day, right? It's the tortoise and the hare, right? That's what it is, man. Right? If you can be the tortoise, you can just get where you need to get. And again, I'm stating all of this based on my own experience as a spine patient, right? As a surgery patient, not as a clinician, because I can tell you now, I train 6 days a week, right? I do 3 to 4 weight training sessions, and I do 2 to 3 cardio. That just changes every week. And then 1 day complete rest. I'll just walk or do whatever else. And the consistency of me being able to train over and over and over and over again, my body's responding fantastically well. Now, that's going to change for everyone, but it's just an overriding principle, because the Spine Exchange, and the reason I'm using the 70% rule on the Spine Exchange, is the Spine Exchange is trying to hit many people at one time, okay? Whereas my role as a clinician in PerformanceRx, it's one-on-one, okay? So the best way to attack a large population is to give a general rule, and the general rule is, here's 70%, man. Try it out. And I know my patients are doing it, and they are getting results from it. They really are.
Fantastic. I like the, as you said, consistency trumps intensity. And applying it to, I mean, there's, various terms come up with it. I know McGill uses his tipping point, biological tipping point. We often use in clinic the load versus capacity paradigm. And it's back to what you said before about respecting the spine. I often say to patients, respect biology. And, for example, if you're training powerlifting, you've got to give, it's more about adapting bone. Obviously, you need some strength in it as well. But bone has a different adaptation schedule to muscle, to tendons, etc., etc. And as you said before there, it's trying to keep it as broad as possible, but it's staying underneath that tipping point. And sure, in the context of elite athletes, the only time that you really want to cross that, threshold and go past your max is when you are competing, or, going for your PR, or once or twice, maybe 3 times a year. But all that training that takes place outside of that should be really done to build that engine, as you were saying. So on that,
well, Jordan, maybe not. Maybe not. I have some views on that, because I've trained Olympic athletes. I've trained elite athletes at the highest level before. And I'll tell you, okay, it's very difficult when you're working with an elite athlete. Yeah, you can have a textbook and you can say, listen, when you're training, I want you to stop at 70, 80%, and you're going to give 100% at your, when you get in the ring or wherever you go. When you're dealing with an athlete is 100% of the time. Okay, they're a different animal. And again, it's pattern recognition, because I don't care how many textbooks you've read. I don't care how many courses you've been on, right? If you, right, as a coach, as a clinician, or whatever, everyone's choices in life, right? If you can't get into the head of the athlete, if you can't coordinate your thoughts on the same wavelength as them, right, you will never get to understand them. You'll lose that athlete. Okay. And some athletes, right, when they go into the gym, they are going to give 100%, 100%. They're going to empty that gas tank as much as they can, because they want to, it's a high for them. They want to experience it. Okay. And then when they get into the competitive arena, they'll empty at 110%. Okay. So again, with regards to an athlete is a completely different kettle of fish. And again, on social media, there's so much, people comparing general population to the athletic population. They're not the same. They don't think the same. They don't work the same. Their brain's not wired the same, right? Because if they were, then most general population would get into the gym and empty their gas tank, right? Go train a general pop patient, right? And get them to the point of where they're getting into that dark place in a gym. They don't know what that is. They'll freak out. Okay. So it's the same with spine surgery. I've dealt with high-level athletes that have had spine surgery, right? For them, it's another chance. It was an obstacle. They've had the surgery. Let's rock and roll now. And they are going to empty their gas tank over and over and over again. For them, they're not going to really sit now I'm generalizing, right? But they're not really going to sit and try and understand the whole tipping point, because when they've got to play and their life is at stake, or in the sense of their money and their livelihood, hey man, what's a couple of screws and rods and a cage and some bone graft going to stop me, right? If I need to sign for $60 million, I'm going to empty that gas tank every single time. So again, it's a different animal. And I've been very fortunate enough to compete at a very high level myself in martial arts and to work with super, super high level athletes. All right. I get to understand their brain. Right. And it's not an easy thing, man. So
interesting. Fascinating. I thank you for sharing that point of view as well. And I know I've heard a couple of stories with it, and I've had a few patients, obviously, at different levels of athleticism, and some of them will literally say, if they've got a broken toe, just cut it off. I don't care. I need to, finish or get to this point. And so, again, understanding that person, and back to what we spoke about initially, building that understanding of the beast that they are, or their circumstances around them, and applying the right communication to them, and saying, some patients might just want to get through and complete, a marathon, whatever. And if they need to have knee surgery, hip surgery afterwards, obviously, then they're willing to take that. So it's quite incredible to have that understanding. And that's, I guess, why they are elite, those few that manage to, soar near the sun. So on that, when we talked a little bit about walking, we mentioned it a little bit before in your own background for your rehab, prehab, whatever you want to call it. How important is walking? And I know obviously there's a lot of studies showing that patients with back pain might have different walking gaits and all the rest of it. But why is it fundamental to low back health and function?
Plain and simply, it's the most natural form of exercise known to a human. That's why. Everything else is made up. Gym is made up. Sitting on a leg extension or a leg press machine, it's all man-made, man. Okay. I was asked a question on social media. As you know, I don't really respond much on social media, but there was a few different individuals and some questions were posed, right? And the one question was posed and said, what is the best exercise for backs? And one of the respondents turned around and said, well, it depends. There's no such thing. And my response was very different. And I said, absolutely. If you can walk, right? If you have the ability to walk, so in other words, your back pain doesn't stop you from walking, the number one best exercise known to human beings is walking, right? There are so many benefits to it. But what's really interesting is we know that the adaptation of bone comes from loading the bone, right? So I'm not going to get into all the geekiness of it, but when you load the bone, right, which is, remember what I said, it's the shock absorber of the spine. Okay, there's all the blood. So what happens is every time you load the bone, you get optimal adaptation. Okay, and nutrient that you create nutrient drive into the disc through the end plate and a whole host of things, right? And one of the best ways to do that without putting extraneous load on your body, so you're not wearing, you're not holding 100-kilo barbell or anything to that degree, is walking, right? So walking is extremely important because it creates that electrical or that piezoelectric environment because you're actually loading the bone. So I had this conversation with a therapist who works in my facility this morning. So the conversation was, why am I seeing so many post-spine surgery patients? I'll tell you why. Again, it's my opinion, is that people go for a fusion. They're feeling fantastic within 3 weeks. They've got over the surgical site pain and whatever else, okay? Because you do. That's what the human body does, right? It heals really quickly, or at least it reduces the pain. Once the trigger's taken away, it reduces the pain really quickly. And then guess what happens? They're back in the gym. They're doing their physiotherapy. They're with their chiro or whatever it is, right? And they're doing a whole host of things. And then 3-4 months down the line, bam, right? They're at my office. Okay, because they're in a whole host of pain, they're in everything. My recommendation to all of my patients, right, post-fusion, for example, go walk, because you need to load the fusion, because that's how the bone grows and how it takes place. So when you walk, guess what, right? You're utilizing what your spine can tolerate, right? You're utilizing your body. Okay, it can adapt to the weight. You're not overloading it. You're not overstressing it. You're not understressing it, right? Just walk, all right? And guess what happens? As the spine adapts and it gets stronger and the discs are being flooded with beautiful nutrition, right? Then you can start gradually progressing. So for me, Jordan, research or no research, man, right? Walking is fantastic if you are able to walk. It's a highly nutrient-dense exercise for your spinal bones and for your spinal discs.
Well, hopefully, if listeners take away one thing from the podcast, it will be to walk, right? And the benefits that you spoke about there. One final part that I wanted to touch on, again, I'm cognizant of your time, with relations to more, not so much about injury context, but more so about, I guess, performance, or more so about training, is the hydrostatic nature, or hydrophilic, I should say, nature of the disc. And again, we'll keep a context to not specific to a person in pain, but can you just quickly explain very simplistically, a lot of my listeners have gone through it before, and we explained it a couple of times, but how you think about the hydrophilic nature being the diurnal changes. I know Jerome himself has done quite a bit of research around there. How you think about that in terms of training, specific times of the day, specific exercises, etc.
It's simple, right? For me, okay, if someone is of a chronologically younger age, they have a definitive discogenic pain generator that we've tested and we've seen radiologically, right? And they've got no other potential issues at that time. And the mornings are the most provocative time for them, because without, again, getting into all the stuff, right, when you unload a disc, so when you lie down, right, and there's no axial or vertical compressive load, right, that disc will imbibate with fluid. It will suck up fluid, because that's what it does. And then in the morning, right, if you've got symptoms, be it back pain or radicular type pain, it's probably not best to then expose the spine to extreme loads and ranges of motion first thing in the morning, okay? However, if you've got an elderly patient or someone who's chronologically more mature, I'm trying to be as politically correct as I can, and they don't have a very bulbous disc and a very well integrated disc, and in actual fact they've got no disc left, and they wake up in the morning and they've got back pain, it's most likely an arthritic thing. It's not a hydrophilic thing in their disc, because they literally, on the Fuhrman scale of disc degeneration, they're right at the end of it, right? So there's not much collagen and nucleus left and water left inside of the disc. So they're probably waking up and they've got arthritic type pain. And I would be less concerned in those patients if they start moving a little bit, because that movement may actually help them out, right? So again, it really depends on what the primary pain generator is. And that's when, in this instance, structure for me is important, right? Is it facetogenic arthritic pain? Is it discogenic hydraulic pain, right? Or that hydrophilic type induction of pain, right? So on that basis, it really all depends. And the worst thing is, I trained the South African Olympic rowing team, the pairs, right? So I was one of their strength and conditioning coaches. And unfortunately, these guys are subjected to getting on the water first thing in the morning, right? Because the water is like glass, right? They can't go in the afternoon because of weather changes. And rowers have got, for most part, they've got a lot of back problems, right? Just purely because of the amount of repetitive load that goes through the back. But it is what it is. So what I would say to my rowers is, hey man, if we got to row at 6 a.m., don't wake up at 5:45, right? Try wake up at 5 or 5:20, walk around, allow the disc to sort of, lose its lose its height and lose that water uptake, and then let's get you on the water. So again, it really, I'm not governed by the hydrophilic nature of the disc. I'm governed more about what the person has access to, right? And especially if I'm dealing with a high level athlete, sometimes, it is what it is. If a rower has to row at 5 or 6 in the morning and they don't want to wake up earlier because they need the sleep and recovery, I'm like, not much I can do, man. But with regards to Gen Pop, yeah, we can change a whole host of things. You don't want to sit for too long. You want to lie down a little bit. You want to stand a little bit. You want to sit a little bit. Yeah, all of those things are taken into consideration. But I'm not absolutely obsessed about the hydrophilic nature of a disc. That just is it is what it is, and that explains why discogenic patients shouldn't be doing crazy things, within the first maybe half an hour or 40 minutes of being awake. Now, it all came about, though, Jordan. So to give you context, right? It all came about because people were wondering why they weren't getting better. Discogenic patients weren't getting better when they woke up in the morning and before they got out of bed, their therapist told them, pull your knees to your chest and go side to side. You need to mobilize your spine before you get out of bed, right? And then all of a sudden, they were getting more back pain. They're getting more radicular pain. And then it was through Stu's studies to understand the hydrophilic nature of the disc that people then thought, okay, hold on a second. Maybe that's not the best thing to do first thing in the morning, right? So now, unfortunately, people have read, back mechanic, and now they've taken it out of context. And, now, if I've got back pain, I mustn't do anything in the morning. No, not at all. It's not what we're saying. We never said that. Okay. What we said is maybe if you've got discogenic pain, pulling your knees to your chest and pushing end range stretches and those type of things, that's not the best. Right. So can you see how, again, it's taken out of context. I've got many people, right, that have got back pain, discogenic back pain, right? And the only time that they will do the program that I give them is upon waking, right? Because their job dictates that by the time they get home at night, they are absolutely done for. They're not going to do the program. So you know what? I will lessen their ranges. I will lessen the load. We'll change a couple of things. Get out of bed, get on the floor, do your stuff. I'd rather you do it than not. Right? So again, it's very, very contextual.
Yeah, fantastic. Well, thank you very much for, I think, again, social media and all the rest of it is very polarizing because obviously you don't have enough time to explain, and that's where the difficulty comes into it. But it's always, as we said before, context is key. So now to finally wind up, because I appreciate all the very interesting information. I wanted to myself, just for my own personal I guess selfishness, there were so many things that I wanted to divulge and go into different avenues. But moving on, just to wind up, last couple of questions, and that is, if you couldn't be a spinal expert or have the career that you do have currently, what would you have wanted to do?
Well, I don't live my life with regrets. I really don't, right? So for me, I'm super, super blessed to be able to do what I love every day and what it's afforded me to do, with regards to working with, guys like Stu and my surgeons and that. Man, I tell you, I'm having an absolute ball, right? I really am. However, okay, if I wasn't a spinal expert, man, oh man, would I have loved to have been an actor. I wanted to be a martial arts Jean-Claude Van Damme Hollywood actor, man. That's really what I wanted to be. But the spine found me and I found the spine, and that's how it landed up.
Fantastic. Well, it's funny you mentioned that. I see a little bit of Jean-Claude Van Damme resemblance there. So maybe you could be a stunt double or something along those lines.
I'll tell you, you've made my day, man.
Brilliant. Right. And then one final one to wrap up. If you could travel back and go visit a young Joel, what would be, if you could only give one piece of advice, what would be the one piece of advice you would give?
Oof. If I could only give one piece of advice, probably the hardest thing that I find to do myself, okay, even to this day, don't sweat the small stuff. Genuine, right? It's one of my hardest things to overcome in my own personal life. But if I could go back and I could look at Joel Proskowitz's life again, I would try give him the tools to not sweat the small stuff. However, Jordan, maybe it's due to me being dismissive of that, that's allowed me to get to where I am today, right? So on the basis, you see, and people always ask me this, these questions, what would you have done? And in all honesty, right, I wouldn't have done anything different. I'd still have all my spine surgeries. I'd do everything exactly the same, because it takes me back to a very, very close friend of mine, okay, who's very, very famous in the fitness world, right? That's how we joined up together. And he turned around to me once and he said to me, Joel, don't be quick to give your kids the things you never had, because it's the things you never had that made you the man you are today, right? And he said that to me once, and that has stuck in my head massively, Jordan. So as I say, if I had the ability, which I don't, right, to not sweat the small stuff, that's probably the advice I'd give to Joel Proskewitz 2.0. However, because I'm not 2.0, because I'm still 1.0, right, and that's how I'm going to be, I'm actually, hey man, we're good.
Brilliant. What a way to wrap up. Thank you again, Joel. I really appreciate it. It's been an absolute honor and pleasure to just dive into talking with you. And like I said, we could talk for hours and hours from a selfish point of view, but I thank you again for giving your time. And I know the listeners out there will take a lot of valuable information away from it. So thank you very much. I really appreciate it.
Jordan, my pleasure, and best of luck with your career and your podcast. And to put out information for your listeners, it's fantastic of you. And I wish you and your team at your clinic in Perth the best of luck. So, and I'm sure our paths will cross again one day.